I'm going to talk today a little bit about digit amputations. By a show of hands, how many folks have had a client or patient who's actually had an amputation? 1, 2, 3, 4, 5, 6, 7, quite a few. So what we look at in hand surgery is the combination of how many digits are involved and whether or not the thumb is involved. The thumb is the most important digit in the hand. For single digit amputations, it's a little bit different, and for multiple digit amputations, it can be a very, very vexing problem. The good thing about this is that you as case managers can intervene on the patient's behalf to try to get that patient either back to work or have the organization understand that there's probably a remote possibility that this patient is never going to be normal. There's the structures in the hand, specifically the digit involved the skin, tissues underneath the skin that are called the subcutaneous tissue, as well as tendons. And there are 2 in each individual finger, one of those which splits. And each one of those digits has 2 major arteries for the size of the hand, as well as 2 nerves. And then in addition to that, there are very, very small receptors on the finger that allow for very, very discriminative understanding of our environment. So when somebody injures their finger, or multiple fingers, there's always a psychological component to it, because the hand is the way that we actually communicate with the world. And there's this wonderful diagram that was done that demonstrates the amount of neurons in your brain that represent the hand and the face. And there are quite a few. So understand that somebody who's had a hand-related injury is most likely depressed because of the injury, especially if it's a chronic injury, and it has affected their life to the point where it could be very, very altering. That's not to include some other things that could go on that allows them to develop into a spiraling problem of pain. So what does a caseworker do? A caseworker, you guys see a lot more than we do as physicians from the business side, because you're probably getting calls from insurance companies as far as when is this patient supposed to go back to work. We as clinicians are trying to get the patient better. So you're right in between the two, and I think that it's really important to understand that as nurses, which I'm assuming most of you are, you're still advocates for the patient. And I think that we can come to a happy medium where we advocate for the patient and do what's right for the insurance companies who are paying for all of this. Over the course of the years, I've seen case workers that spread the gamut, and it's great to see you all here, and I hope that we have more conversations like this, so that you can understand what we see and we can understand what challenges you. So with regards to an amputation, usually these amputations require what's called a replant, and a replant is where you hook up the artery, you hook up the nerve, you hook up the bones, you hook up the tendons, and you're in the operating room for quite some time. A lot of patients who are have work-related injuries can't really afford the amount of time off work that a single-digit replant requires. So I, as well as some of the other hand surgeons, most likely have had patients who have simply just asked for it to be amputated. And the way that we do that is we do what's called a ray amputation, and we go from the tip of the finger all the way down into the hand and then close the web space. Those patients can see quite an accelerated return to work as opposed to somebody who wants the digit back on. Usually when you have a single-digit replant, single-digit amputation, or even sometimes in multiple-digit amputations, patients are asking to have every possible modality done for them to go back to a pre-injury state. And I think it's important for the clients or the patients to understand that that's not going to be possible in most cases with a amputation that's in the digit, because those structures that I indicated to you before, the tendons, the nerves, and the bones, need time to heal, and the way that they heal is with scar. And then when you have a scar, mobility is significantly altered to the extent where that patient who most likely was working with his hand before the injury now has a hand that, although the digit's back on, it's somewhat crippled. So understanding that that is the case when you get a client like that, you have to inform who's ever involved with insuring this, that this is going to be a fairly long road, and it's not going to be the kind of thing that's going to get better overnight. With regards to pain, we have what's called regular pain associated with any kind of injury, and we have this complex thing that's called complex regional pain syndrome, and it can either be sympathetically related or sympathetically independent. And that really spirals the patient into a problem that can alter their lives significantly. So when you're seeing these patients, realize that they may not be telling you that they're depressed. They may not even know that they're depressed. Their lives have been significantly altered by this unfortunate traumatic event. And although you might not be able to solve all of their problems, you can be the shoulder that they cry on from time to time. And I've seen that time and time again with case managers that I've worked with, that without them, I really couldn't accomplish my job, because when I'm talking to the patients about things that they need, such as secondary and tertiary surgeries, the patients really aren't even considering those things because this has been such a devastating injury. So with that said, are there any folks out there who might have questions? I got the yellow flag right now, and I want to see before and I've got 4 kids, so I can answer a lot of questions. So, yes?
For recurrent neuroma formation, in a partial amputation with a tip, how far down do you think you have to go? I mean, it seems like, you go and then another one forms. You cut a little more and another one forms.
Yeah.
What would be your best recommendation?
Well, it sounds like you've seen that problem before. The question is, with recurrent neuroma formation, with multiple recurrences, how far are you going to go before you're going to stop? A neuroma is a bundle of nerve tissue at the cut end of the nerve, and this bundle of nerve tissue still has some of the receptors that are involved with things that are called proprioception and nociception. So these clients actually have an exaggerated response to tactile stimuli. And so for that reason, them working with their hands prior to surgery, prior to the injury, they cannot go back to work because the fingertips are very, very sensitive. One of the things that's done in these instances is a nerve can actually be implanted into bone or deep into subcutaneous tissue, because the real problem exists where the nerve is actually finding fibers that actually go to the skin surface. So you have to interrupt that avenue at some point or in some way, and we do that with burying it deep within the subcutaneous tissue, and that's the skin, that's the tissue beneath the skin, or sometimes we can actually bury it in bone, or sometimes you can cover it with biological tissue to impede its ability to find itself back to the skin surface. With a neuroma, it's not functioning as it should be, so resecting it proximally doesn't really cause any harm for the client as well. But burying it deep within some kind of structure usually helps prevent its recurrence.